I definitely wouldn't see myself as any kind of expert. I think it's just a continual journey of exploration and reflection that will last my whole career, and we'll talk about this more and more, but for me the compass point in my journey is that the patient's always the cultural expert in the room, and I work out from there. So I guess just going back to maybe what seemingly is a bit of a dry slide, but just because this often comes up when I'm sort of chatting with registrars, that sort of key difference that I think people just starting out on this journey have between their knowledge of cultural awareness and cultural safety. And just to make the point, I guess a lot of registrars, when we start talking about Aboriginal health consults, make quite broad generalisations and stereotypical assumptions, sort of things like, I'm sure we've all heard this, Aboriginal people don't like to make eye contact during consultations, they don't feel comfortable, or Aboriginal people will want an Aboriginal health worker present during consultations, or they'll need someone as a translator. And that may be true for some people, and that's sort of, I guess, cultural awareness at that level, that there are cultural differences that we need to respect and explore. But cultural safety is taking that one step further and recognising that this person is an individual, and even within their own culture, they'll be influenced by their level of education, their prior life experience, their prior experiences of the health system, what part of Australia, what tribe they come from, all these other factors come into play. So cultural safety is about recognising that individual in the room and respecting their experience, and in some ways lifting that burden off ourselves to be the knowledgeable expert, and to be able to really just hand that vulnerability back to the patient and reassure them that we're there to listen and to be guided by them.
And I guess as well with that, the difference between that kind of cultural awareness and safety as well is awareness is a knowledge about a culture, but safety really is a reflective practice. And as such, it's something that develops and evolves over time, and it needs to be adaptive and a transferable skill as well. And I think particularly for cultural safety, it's important for it to be not a solo reflective practice, because if you're reflecting by yourself, there's that risk of reinforcing stereotypes or preconceived ideas that may not be correct, but cultural safety is best as a reflective practice with other people. Kind of much as Sally and I have found in preparing this talk, we've been able to talk and reflect and kind of challenge each other in ways that wouldn't have happened if we were doing it by ourselves.
Excellent. So I guess we just following on from what Mary was saying, it's been so great to have that chance to reflect, and Mary has a lot of experience in mainstream, and it's been really interesting for me to sort of hear about her experiences and how she approaches things. There's always something new to learn. So again, just that this is a lifelong journey, a career-long journey. And I guess just reflecting back to what I said on the last slide, that for me, the way I think I've tried to keep myself as culturally safe as possible is just that constant acknowledgement that the patient's the cultural expert. So something that perhaps was a bit daunting at the start of my career, where perhaps I felt that burden to be knowledgeable about how to do an Aboriginal health consult and having to get things right, I think allowing that vulnerability to creep in and just acknowledge that I'm never going to be an expert, I'm not Aboriginal, I'm never going to be an expert, and almost use that as a positive aspect of the consult to gradually hand some of that power back, and particularly on remote communities where people might be feeling quite shy and worried about this authority figure from Broome or Kununurra showing up to have a consultation, to be able to hand that control and power back to the patient and allow them to be the expert. I can share my medical knowledge, but it's okay for them to be the cultural expert in the room, and I'm learning from them as well as them learning from me. So we kind of even the playing field and hopefully open the door for them to feel more comfortable.
Yeah, I agree with that. I think often with Aboriginal health, there's these feelings as doctors of being inadequate or not knowing enough, and that we need to be, I'd love to do Aboriginal health, but I need to know more before I plunge in so that I'm culturally safe and good at it. But I think I've learnt over time that as a reflective practice, I don't have to know everything, and there's too many nations to know everything about anyway. But that doesn't stop me from being culturally safe. Like Sally said, there's the individual in front of you, and kind of acknowledging them and asking them what they need from us is enough, and that feeling of inadequacy shouldn't be a barrier to providing good health care. I guess acknowledging as well that a patient's Indigenous status or not isn't the only culture in play in that consult room. Medicine carries a culture within itself. So even an Aboriginal doctor, whether they're from the same community as their patient or not, will be consulting in a cross-cultural way as well. So, you know, we're talking about Aboriginal culture and cultural safety in this context, but actually there's more cultures to be aware of, be it religious, be it sporting for some people, or even just the culture of medicine. They all have an interplay in our consultations.
Excellent. And I guess, so just again, reflecting on that sort of juxtaposition of Mary has this wealth of experience in sort of mainstream practice, and I guess most of my experience is both in the Kimberley and here is in Aboriginal community controlled health services. And I guess to me, this is more than just a friendly building with artwork and resources that represent the community. I think these services embody self-determination of health, because these services are run by the community, and the community can determine their own health needs when they have input into the design and the running of a service. So, for example, VARS is run by an entirely Aboriginal board, and that board is actually elected by the local Aboriginal community at the AGM each year, and the CEO is Aboriginal. And of course there's quite understandably a positive discrimination policy at every single level of employment, that we're working alongside Aboriginal staff, and our managers are Aboriginal. And I think that really does embed a culture of safety and self-determination. And I think that the history of that can be quite fascinating as well, that you know, these services sort of came about in the early 70s because people didn't, I think quite understandably, didn't feel that their needs were being met in mainstream. And there's just historically so many, you know, interesting stories about how services started. Like I think in Broome, they started in 1979 with Brahms, and at the time they had no funding, so the local nunnery let them use the back half of the nunnery to start Brahms, and an Aboriginal registered nurse volunteered to get that service up and running. No one got paid for months, and I think eventually doctors flew up from Redfern AMS and volunteered and actually camped out the back of the nunnery on swags, and eventually funding was obtained, and it's now obviously a huge service that services quite a number of communities as well. But I find that the history of these, a lot of these services, quite fascinating. And I guess, again, I'm sure there's many people listening who are very familiar with what an Aboriginal health service looks like, and why it's culturally appropriate. I won't sort of labour the point, but just in case, just to briefly mention, obviously the focus is on population health and prevention, and we're very fortunate to have everything co-located at VARS. So we've got physio, OT, paediatrician, midwives, speech therapist, we've got the dentist, and financial advice. We've got an Aboriginal health worker who specialises in NDIS applications, so extremely fortunate. And we can also have longer appointments. We try to be as flexible as possible around appointments and late attendances, and you know, the rooms are bigger to accommodate family groups being able to be seen instead of trying to get kids to wait outside, etc. So that's just an example.
And I think these Aboriginal community controlled health services play a very important role in our country in terms of delivering care to our Aboriginal communities. But I interestingly read recently that the majority of Aboriginal and Torres Strait Islander people still access their healthcare through mainstream general practice services, and there can be multiple reasons for that, including distance from their closest ACHO. Some people actively choose to go to a mainstream practice, whether it's because they've got family members at the local service and they don't feel comfortable going there for that reason, or many other reasons as well. And so whilst these services play a really important role in providing culturally appropriate and safe care to our communities. That's not a reason for mainstream general practices to go, well, you can go to the AMS, they'll look after you there. If a patient turns up at our practices, we need to make sure that we're offering culturally safe care as well. And I guess recognising there are still barriers to people accessing the local AMS, or, just again, that individual determination is that they want to go to a mainstream practice for their own reasons as well. So I think just making sure that we've got that lens too, that just because there is a specific service, it doesn't mean that we can abdicate that responsibility to look after the whole of Australia's different communities too in mainstream practice.
I think that leads into the next point quite nicely.
Yeah, so I guess talking about what can make people feel more safe in mainstream practices, it's really simple things. Pictures of the Aboriginal and Torres Strait Islander flags, artwork in the waiting room or in doctors' consults rooms, having an acknowledgement of country and a welcome in the waiting room when people come in as well. I think for myself, I was fortunate enough at bars that when I left, one of the health workers had given me this small kind of photo-sized painting that she'd done, and that's been something that I carried with me into every consult room I've been in since. And no one's ever specifically brought it up or pointed to it, but even as a reminder for me of my experience and where I've come from, and someone might never say, oh, that makes me feel safer, but it's nice to have these things kind of around the practice, because it's kind of that subconscious feeling of safety too, I think, sometimes.
Excellent. And I guess this is just a couple of photos of, again, I guess we're very, very lucky at bars that things are quite welcoming. And on a cold day like today, there's a roaring fire in the waiting room. And often, I'm sure Mary would remember, there's people playing guitar or someone who plays a gum leaf, and just a really lovely place to hang out. And I think, again, reflecting back to the history where, these services were commenced by the community to meet their needs, the waiting room's somewhat of a meeting place as well as just a place to wait for the doctor. And obviously during COVID, that was a very difficult time because we wanted to limit the numbers in the service, but I think we lost a really important community meeting space. And then this is another photo of next to the fire of the waiting room with this lovely serpent weaving through the floor. And we have all sorts of spaces like a children's play area, an elders garden where people can sit quietly when it's not too cold outside. And reception has been actually remodelled since this was taken, so it's a bit more welcoming and those screens are gone. But yeah, everything's been designed around what the community has felt was appropriate. And this, I guess, just moving, so we've sort of woven our way through that welcome in the reception, and when the sort of, I guess Mary and I kind of were looking at the patient's journey through the clinic, whether it's a mainstream clinic or an Aboriginal health service. And so we're just entering the consult room now. And I guess just again acknowledging that there's, I'm sure, a lot of expertise among the people listening to this talk, and are not in any way wanting to sound like an expert here. But I'm just sharing a few sort of the things that I've found particularly helpful and perhaps helpful when I'm talking to registrars as well on their journey. And one of the things I find most helpful is actually this map. And not just having it hanging as a sort of to show that I'm interested, but to actually bring it into most of my consults. And I think with Aboriginal consults, I tend to probably do a lot more focus on the social history a lot earlier in the consult. And I think that's probably my way of showing that the door's open to discuss other things other than just purely that medical model, and to hopefully help people feel a bit more comfortable and relaxed. And as part of my social history, I would usually, in some way, ask people about where they're from, I don't do it directly because, again, I think that runs the risk of people feeling that I've stereotyped them, or, you know, every Aboriginal person must want to go and spend time on country. And I'm very aware that, you know, perhaps some people with a history of the stolen generations who sadly haven't been able to trace their family, that might be really confronting and re-triggering. Or it might also just people, I don't like to feel that I've been generalised and stereotyped, and I'm sure other people don't. So I tend to use narrative a lot and say something like, oh, some of my clients, you know, find that spending time on country is really healing, it's really important to them. And is that something that's been helpful for you? And I have to say 90% or more of the time, the client or the patient will stand up and move to the map themselves, and we'll have this lovely discussion. And often, you know, I'll be shown where their country is, where their mum's country, their grandparents. And I just learn so much myself. Like, it's a really rich kind of sharing. And a few times when consults have been sort of escalating for whatever reason, to be able to go from sitting and having direct eye contact and move our attention to something not other than each other and start a discussion that's completely on a tangent is one way I often de-escalate consultations that might be getting a bit lively. So that's another tip. And I think I use this all the time with registrars, particularly when teaching on Zoom for PEP across Victoria. And I'll often, you know, when we do the what if question for case studies, etc., what if the patient was Aboriginal, I'll often lead into a discussion perhaps of what tribal lands they're practicing on. And I'm surprised at the number of times registrars don't know. So rather than just telling them, I give them the link to IATSIS in Canberra, and it sort of encourages them to obtain one of these maps. It's only $14, and they send it out to you in a couple of days so that they can actually then get that map, but they've got something to look for. They're going to find what lands they're practicing on so that they know from then on, and hopefully hang the map on their wall and start using it a little bit more. So that's been one of my big useful things on my journey.
I think we're talking about being culturally safe, but the first step to that is actually identifying your patients that do identify as being Aboriginal Torres Strait Islander. And I guess this is probably a bit different in a mainstream general practice to an Aboriginal Health Service, but you need to ask. There's a simple way to ask, and I'm fortunate that I very early on as a registrar learnt to ask, and it's something I commonly ask. It's very clear on best practice and your main general practice systems, whether that question's been asked and filled out before. And so I find that even patients that have been at the practice for a while go, oh, look, this information's just missing. Do you mind if I ask, do you identify as being an Aboriginal Torres Strait Islander person? And they'll say yes, no, or, answer as to whatever's true of them. But it's interesting how commonly records aren't filled in for this sort of thing. I remember working in Tasmania a couple of years ago, because I was so used to it coming from Victoria and VARS. I'd just be asking everyone, do you identify as being Aboriginal Torres Strait Islander? I was seeing a lot of new patients in a practice and was identifying people, but then working and talking to some other GPs and educators in the area, it was quite surprising to me hearing this kind of narrative around, oh yeah, we don't have many Aboriginal patients in mainstream general practice in Tasmania. And I found that quite interesting because I'd identified some, and like my kind of subjective experience was that I was seeing as many patients in Hobart who identified as being Aboriginal or Torres Strait Islander as I had been in metropolitan Melbourne and in Warrnambool as well. And it made me go digging and actually looking at the numbers and the percentage of population of Aboriginal people in Tasmania compared to other states in the country, and it's not lower. I don't think that's a surprise to people, but there was this kind of perception, and so people weren't asking because they didn't think people were identifying. And I guess there are some other historical things in Tasmania about why perhaps some parts of the community weren't identifying in mainstream practice as well. But not asking, someone choosing not to identify as their decision, but not being given the opportunity, I guess, is another thing entirely. And so, I guess just remember to ask the question. And if it's not there and they've been a patient at the practice for 20 years, I've still asked it and people are okay with that. But at least it, kind of gives that opportunity to start having that conversation around culture and I guess the closing the gap sort of measures as well.
I think that's such an important point. And I guess another kind of example perhaps of using narrative that I find in consultations, I'm constantly surprised at how many people still see a role for some kind of traditional healing. And again, I wouldn't ask that directly because I think it runs the risk of that sort of stereotype, all Aboriginal people need a traditional healer, and that's not the case. But I often would sort of say, look, some of my clients find that they've had a role for traditional healing in their recovery. Has that been something that's ever been important to you in the past? And I think very often the answer is yes. And it again leads into this wonderful discussion about what their approach to that is and how they access that in Metro Melbourne. That's really interesting. I think a recent study from the Territory found that 50% of clients had used traditional healing within the last month. And I do think it's a really important thing. I guess perhaps one of my own assumptions was maybe that in Metro Melbourne that would be different. And that's not, when I've sort of asked about it, that's not been my experience. And just the rich learning and finding out what is being used and how it's accessed is really helpful.
I guess just remembering as well that good cross-cultural communication is actually just good communication, full stop. What's going to work well in a communication, from a communication point of view in any consult, and what we're teaching our registrars and PET participants are all the tools that can enhance and open up that cross-cultural conversation as well. So open-ended questions, like Sally said, taking that social history, active listening, where you ask an open question, someone gives an answer, and you reflect back your understanding so they can kind of challenge or correct you if you've not got it quite right. And motivational interviewing, where you're asking your patient, giving them information on what's going on, but then kind of working with them to work out solutions to how they're going to address that health issue, and supporting them in that rather than being prescriptive in how you say, you have to stop smoking and lose weight and get more active. You need to sign up for a gym and things. Instead of doing that, which, we shouldn't be doing in any consultation, asking the patient, going, how, it sounds like you're feeling that your weight's impacting on your health here. How do you think that you can lose some weight? What would work for you? And then encouraging them to come up with those solutions. And that's just allowing the patient, again, to have that self-determination in their own healthcare and work out what's going to fit with them and their culture and their lifestyle and, their restrictions on what's plausible or not for them at that given time as well.
And I guess one of the other things that perhaps I didn't manage quite so well when I was starting out as a registrar in remote communities was this first point of allowing time and avoiding overwhelming the patient. And I think, and I do see a lot of registrars feel that burden as well starting out. It's certainly something I felt, that we feel perhaps that people aren't presenting that frequently, or maybe they won't come back. And so this intense pressure to try and deal with everything. And these poor clients on a remote community leaving with my long list of everything we were going to fix in one consult. And I think it was probably the biggest barrier to them coming back to seeing me, heading off to Bidjadanga community shop, being told to eat more healthy foods when the truck comes in once a week and the food's very expensive and the veggies probably run out after 3 or 4 days anyway through no one's fault, So I think I've really learned that perhaps in the first consult, the best thing you can do is engage someone so they come back and and just start the conversation. And I always sort of chat with registrars, because I think general practice can be quite isolating and we're all very busy, and I try and encourage people to see the best feedback is when patients come back and see you again. That's the best, most reliable feedback you can have. So our job is to try and engage people to the point where they're comfortable to come back and see us. And a really nice lead on from what Mary's just said, that of course, as everyone here, you know, who are all experienced would know, you know, that sort of not prescriptive, not didactic sort of consult, but that very reflective, motivational interviewing kind of approach.
I find that works in mainstream practice as well. Like I don't have the time in my appointments to do everything at once. And it ends up overwhelming not only the patient, but me too. And then I feel stressed and frazzled for the rest of the day. But recognising, I think, and this has been something I've learned from motivational interviewing, is that I don't change people. I can support them in their change and ask them, you know, how I can support them in that. But at the end of the day, if they take that medicine, if they do, you know, quit smoking and things, that's their decision and they've done that. And so, you know, in a consult, I can say, well, we've got time to deal with this. Well, it'll take time to sort out these other things. You need to come back. And then again, whether they come back or not is their decision. And I guess in offering that support, kind of asking what sort of things will help them. Is it, you know, what can I do to help you do the things you want to change? How can I help you stop smoking? Do you want me to have regular appointments with you so that we can check in on how you're going? Or is that actually a burden for you? Do you want me to help talk to the pharmacist to make sure that you've got a regular supply of the medication we're using? Or, you know, just kind of exploring with the person what they actually need from me and how I can best support them, rather than assuming how I can best support them as well.
I think that's so true. And I think one of the other things I've found is you know, often when we're talking about Aboriginal health, there's an assumption that we'll always want an Aboriginal health worker or Aboriginal liaison officer present. And particularly, you know, many Aboriginal health services, particularly in remote areas, that the Aboriginal health workers on site may all be members of someone's family, and they may explicitly not want someone present. So I think it's really beneficial to always ask in a non-direct way, and just, but leaving the door open for someone who's not feeling that confident to be able to say no, in maybe not in the most direct way themselves, that they're not comfortable with Aboriginal health worker being present. But I think it's also really important to remember that this can be an amazing resource. And just as another example, recently I had a client who had, you know, a very, very obvious, very large DVT. And I could see that they knew all of that. Clinically, there's no question, and they were very high risk. And they'd been through all of that 2 days earlier, and they came back they hadn't quite got to emergency yet, and they came back to discuss it with me 2 days after the initial consult with someone else. And we spent maybe 3 minutes talking about the DVT, and we spent 40 minutes talking about country and plans and social history and just all the other stuff that had happened and why it was so difficult to go to hospital. And at the end of that, I sort of mentioned the possibility that the local hospital, you know, that they would go to, this was the ALO, the Aboriginal Liaison Officer, and the client immediately said, oh, so-and-so, oh yes, absolutely, oh goodness, okay, well if you get her to meet me at ultrasound and you organise the ultrasound, I'll go to do the ultrasound, and if there is a DVT, then I'll go to emergency with her if she's going to sit with me. And it just changed. It was such a game changer, and that's exactly what happened. And there was a very big DVT, and it went from perhaps wandering, you know, that client perhaps leaving without treatment to going to hospital, getting the ultrasound and going straight to ED. But the Aboriginal liaison officer was there with her the whole time, and they knew each other quite well, so it worked out really well, and they got the care that they needed. So I think it's really significant. And I think another barrier perhaps sometimes obviously in an Aboriginal health service, we're so lucky to have a lot of these resources on site, but I think it can be hard, and particularly registrars often ask me, well, if I'm not in an AMS, how would I contact that person? And just a little plug that the health pathways actually have all been updated, and all the contact details and those sorts of resources can be easily found. So that can often overcome some of those barriers too. And I guess, again, I know that, that there's a wealth of experience in the audience. And so I don't want to sort of labour a point, but I think I do try and always just carry in my mind that the impact of intergenerational trauma, it just can't be got past. I think it comes into almost every consult, complex trauma, complex PTSD, and it can manifest in so many different ways. One example at the start of the pandemic, when the AstraZeneca vaccine came out and was widely circulated, and again, not making any generalizations because most of our clients were so keen to get vaccinated, but there was a small group of elder women who, from a particular part of Australia, and I won't but for confidentiality, but who said, we're telling the younger girls not to get the vaccine, and when that was sort of talked about a bit, it became apparent that when they were young, they'd been asked to get a particular vaccination, which actually turned out to be a contraceptive without their consent or knowledge. And so one can completely understand that that was their lived experience, and that they were very reluctant, to put their hand up for a vaccine that came out before the rest of Australia got it, which was an added layer of anxiety. And so I think that's just one small example, but I think there's so much. I think this just plays such a huge role in day-to-day consults. And I guess just as a final point, again, reflecting on perhaps some of the things that I've hopefully gradually learning over the years, but perhaps one of the things I've had to learn is that in my own practice is cultural differences don't need to be a barrier to care. I think perhaps at times I've had that tendency to sort of think, what if I make a cultural faux pas, and you sort of hold back. And I think if we just be vulnerable, hand that role to the patient. They are absolutely the cultural expert in the room, and to be able to keep checking in, keep making sure that we're culturally safe, I think we can lift a lot of that almost burden off ourselves to need to know everything to be good at Aboriginal health before we give it a try. And I think particularly for registrars, that can be such a huge burden to lift, that the patient's the cultural expert. And quite reassuringly, when I was writing this talk, I spoke to one of my long-term patients, and he said, look, Sally, I'm from a part of Queensland. I grew up on a remote community, very traditional upbringing, and I come to Victoria. I'm not an expert. I'm Aboriginal. I'm not an expert. If I'm dealing with people at work, in my job, I need to constantly check in with them and find out what's appropriate here and what's appropriate for their individual experience, not making assumptions about what they'll need as an Aboriginal person. So, don't feel that burden to need to know. It's all about just respect and good communication and asking. That's fine.
Yeah, I think that's right. And I think as well, like when they've done research about health workforce and Aboriginal and Torres Strait Islander health, they've found that there's a lot of people who are interested and who want to work within our Aboriginal communities, but are prevented from this, I guess, feeling of inadequacy, feeling like overwhelmed by, I guess, some of that history and that awareness. I think there is a point where sometimes the more you know about Aboriginal culture and history in this country, the more of a burden you can feel, and the health inequities and education inequities and everything. You just kind of go, well, how do I start, and how can I work alongside that and be safe? But I guess I've been learning more and more that all I have to do, take a deep breath, listen to the person in front of me, and just do the best I can for the person in front of me. And as Sally said, if I make a mistake, and we're all human, we all will, let's just accept that. Be big enough to go, look, I'm really sorry, I think I might have upset you then, and apologise. Just be really human and genuine with people, and do the best you can at the time that you did. And if you make a mistake, acknowledge it and learn from it. But yeah, it's hopefully those feelings of inadequacy and overwhelm can be, I guess, supported through reflection with supervisors and peers in such a way that we do build this workforce, because it is so needed within our Aboriginal communities as well. And I guess if we just go, is it on the next slide? Yeah. So, I'm lost now. I think this was your one, was it?
Oh, sorry. I was actually going to briefly just mention, I think another compass point to stay safe is just the role of cultural mentors. And for example, I have a couple of people in VARs that are senior Aboriginal health workers, and particularly when a consult doesn't go to plan, I feel very comfortable going to them and saying, look, I didn't feel like it went particularly well. Could we sort of reflect on this together? And I don't think I did my best medicine, and sort of describe what happened. And I think, again, allowing yourself to be a bit vulnerable. I've never felt judged. I've always felt so welcome, and people really want to unpack that with you and work out perhaps where maybe I've not recognised what was happening on the other side of the consult, and perhaps the consult sadly has escalated to the point where it became too hard to maybe even ask in that time, but to then be able to go to someone else and unpack that and just sort of check in and get some tips to move forward and maybe prevent that situation from happening again has been a really great source of learning for me.
I think with that as well, thanks, Sally. Like you were saying about being non-judgmental, I remember meeting this man when I was working as a student in Foster, which is not far from Tari in New South Wales coast, and he was a lovely man, and he was probably one of the oldest males in the community. He was looking after his grandchildren because the parents were otherwise indisposed, and spent a lot of time looking after a lot of people within their community. And I remember a few years later seeing him again. I was working in the emergency department in the Tari hospital, and he presented with chest pain. I remember overhearing this conversation with the seniors in the emergency department at the time, talking about, why is he presented so late? This always happens. Why can't they just come in when they first get chest pain and things? But the reality was, he was never the man to neglect his own health. He was always at his GP appointments, never missed them, was really, really on the ball with things. If he presented late, it was because he was sorting out the rest of his family, because he had other responsibilities that he was working out before he came up to Tari to go into the hospital. And I guess just acknowledging that there's always more to people than meets the eye. They may be, you may think that they don't care about their health, or they're presenting late, or they're being really nonchalant with the advice you're giving them, but there's always something behind it. There's a reason we are the way we are. And I think just remembering that everyone's different, and everyone's just doing the best they can and make the best decisions they can at the time. I found that a really freeing idea in general practice, because I started feeling less frustrated when I had more empathy for my patients, even not knowing the story, but just, I guess, realizing that, that it's their life and their health, and I can encourage them and support them. But in the end, we're all individuals, kind of just trying to make the best decisions we can with the resources we have at a time. And I found that helped me feel less frustrated towards my patients too.
I think that's a great example how sort of those family commitments, and that's such a perhaps something that we can learn from, the extended family role, and that there's that big village around, and that may take priority over health at times. And perhaps in my culture that doesn't happen as much, but I do think that extended family support is something that we can really learn from other cultures. And just, I guess, again, sort of more the nuts and bolts, but there are, and I've there's so many just culturally appropriate resources that I think can help communicate with Aboriginal clients. I've put this one up because I love it, and I think it's not very well known, and I think it should be, this lovely Stages of Change that is painted so beautifully. And I've just on the left there's this is a website that has all of those resources collated in one point, and that's the Australian Indigenous Health Infonet. And there's so many examples of things that can be so useful, like the Kicker, which is sort of the MMSE but written for Indigenous clients, probably more rural and remote, but again, it depends on it depends on the individual, of course, as to who that's going to be appropriate for. And there's obviously the national guide to the health check written by the RACGP. There's also a podcast that comes along with that, with various experts talking about each chapter, and chapters on things like talking about gambling and some things perhaps I didn't feel I got a lot of exposure to when I was doing my training, and has been really useful. And soon there's a documentary, which probably a lot of people already know about, coming out on Netflix, called Take Heart, Deadly Heart, which is about the rheumatic heart disease sort of crisis really in Australia. And that is, I don't think it's out just yet. It's being shown at some cinemas around, but I don't think it's on Netflix just yet, but coming soon. So there's a lot of resources out there. And I think we've got, we can sort of probably share some of those links rather than talk through them. But should I stop sharing and maybe we could finish there and just open up the floor, because I know there's some very wise people around who might have things to add. I'll just see. I think there's a few things in the chat as well. Jane. Yeah. Oh, sorry. I did want to acknowledge Jane's comment. I've just seen it now. Sorry.
I think that's right. I think, there's a generalisation that an Aboriginal liaison officer will be supportive for someone, but then you're also dealing with two individuals, and you need to make sure that they both feel safe with each other too. So, culturally there's that umbrella of, it may be very appropriate, and in general they may want one, but if they find it out it's such and such a person, they might go, oh no, I'm right. For whatever reasons, we all have people we don't get on with, and that's okay. Or we all have people that we don't really feel comfortable sharing our health journey with too, and that's okay, but at least kind of exploring that.
I think that's so true, and I think it just goes back to that not generalising, and that difference between cultural awareness, where every Aboriginal person will want an ALO, every Aboriginal person will need an Aboriginal health worker, to cultural safety, which is the next step, and acknowledging the individual experience of every person, and that really we need to respect that and consult with them rather than make assumptions based on race.
Well, I think it's also around building up a rapport and gaining trust with your patients and the families within the community.
I think that's right. And I guess thinking about those skills though, that's why I was kind of saying that cultural safety is a reflective practice. And one of the kind of things about reflective practice is the skills you develop are transferable. So building that rapport with your community and your patient in front of you, if you learn that skill, then that's then transferable to migrant populations, or working in a different context as well. I've worked within the Aboriginal Health Service context, but then learned from there, and I hope have been able to transfer some of those skills into the mainstream general practice context as well, because I think sometimes you can just go, well, I can't do this because I'm not in an Aboriginal health service, but actually kind of working out new or different ways to do those things as well.
Yeah, I think cultural safety is really important within the hospital environment as well, because there's been clients that I've worked with that haven't felt safe within the hospital, and we all know the history in relation to the trauma and government policies around the hospital environment. But in recent years there has been situations where our community, and some of our clients haven't been at the forefront of the GP emergency doctor and, you know, within eye contact of the healthcare workers within the hospital. I find that quite disturbing because of the vulnerability of our clients and the health issues that we all have. That's a cultural safety issue, and that we need to encourage, you know, that to happen within the hospitals.
I completely agree, and I've got so many examples of where people haven't presented to care, and then, you know, exactly as that example Mary gave, where you see the hospital staff, oh, you know, they don't care about their health, and actually when you unpack that, it's because they've had terrible experiences in that hospital, and this is not years ago, so recently, and some of them are so heartbreaking. And when I've talked to the client, I wouldn't have stayed in that environment, you know, not being fed for hours because they might need surgery, but no one ever came to assess them for surgery, and getting angry. And then because perhaps one could think in that particular situation security was called because they looked confronting, but would security have been called in another, you know, and it was 10 security guards that turned up and the client left and they desperately needed care. It's, you know, I completely agree. I think it's such a valid point, and I think there's a huge cultural change that needs to, in the terms of the hospital culture, there's a huge cultural shift, but not the Aboriginal culture, but the hospitals. Yeah. And I think, you know, the whole point is that, what's the saying? Care that suits the client, not care that suits the service. And I think a lot of hospitals are still providing in that mould of providing care that suits the service and doesn't necessarily meet any of the client's needs.
Totally.
Such a big risk.
I think a generalisation for hospitals, and I think it's amplified in, you know, in our Aboriginal communities as well. Their experience is not a good one, but that hospital culture doesn't fit many people at all across any culture. So I guess the question is, should we reframe the whole system as well? But there's
definitely
commonly a lack of communication, no matter which patient you're talking about, when they enter the hospital system.
It's one of those things, I think, where you sort of see in the patient notes in hospitals where someone's written poor historian, as if that's some excuse. And these days I always sort of look at that and think, poor historian who? The doctor or the patient? Because it's always written as if the patient's a poor historian, and of course that excuses us from actually doing our job. But I actually now see that as a big red flag that the doctor's been struggling, that maybe they're documenting how they've found it.
In the chat, Sally, Loretta's asked, do you have any tips for our website and social media, or for operations staff in general? I was thinking about this a bit, because I was thinking about, I guess, reception staff in mainstream general practices. Sometimes you still hear those comments about, you know, why are they getting CTG scripts, or why are they getting reduced cost healthcare? They've got an expensive car in the car park or whatever. And for one thing, people can spend their money on whatever they decide. That's up to them. But I guess, you know, there is a practice incentive payment that is given to practices when a certain number of their staff have done cultural awareness training, whatever that may look like at the time. And they can't all be the doctors. And so those front of house staff still, you know, are going through these cultural awareness training programs, but often they're online and they're, you know, you kind of just do it. But I think before, where I was saying reflective practice, I think particularly for cultural safety needs to be done in dialogue with other people and in a safe way. Because I think, even Sally and I talking, I'll be really honest and say that map that Sally showed, I do love that map and I know why it's important, but I've seen it so much without that dialogue that Sally gave it behind that I've often found it boring, not really appreciated how it could be relevant to me in my practice with my patients. And I was thinking, how do we get our practice staff to have that experience when there's also confidentiality as well? Do we get them talking with others and in a kind of facilitated way or something? Like I don't have an answer, because I think the experience in the consultation and the flow of the health system is different to that. Like it's a different administration level, and I can't really I can't really tell our receptionists, hey, this person's going through this and this is what's happened, and let's have a bit of understanding and compassion, because that's breaking confidentiality. So I don't know that I've got a good answer for that. Maybe Sally does.
I guess so. Any tips for website and social media operation stuff? That's the one? Is that the
and or for operations staff in general? I was kind of going to that.
I guess website and social media, it's only a few months, but I get my comment with that would be that there's some amazing young Aboriginal organisations around that do incredible website design, but that's more of a longer term issue, and I'm not sure what the future of MCCC, sadly. And operation staff in general, I think that's the sort of cultural awareness, cultural safety training for everyone across the board, so that you're met right from the start with someone who's at least wanting to reach out and is open and receptive and not making assumptions. And I guess the other big question that's there from Karen is about registrar wellbeing, and I think it's such a huge one, and I think it's such a great question. And I sometimes, I think Aboriginal health services, because of the nature of health, people are really unwell and there's a lot of emergency care, and things become quite chaotic quite quickly, not through any fault of the service, but just through the circumstance. And I think I try and spend time with registrars encouraging them to pace themselves so they're not overwhelmed, because when a service is quite chaotic, it has a lot of advantages. Like in a pandemic, things can change from week to week, and it doesn't stress people out that much because they're used to everything changing weekly anyway. So there's some real strengths actually, and I think the camaraderie that comes out of that everyone's kind of in it together and it's pretty informal, is amazing, and that's just such a nice environment to work in. I think though registrars perhaps don't get some of the benefits of that because they're only there for 6 months, so they don't always get to maybe lift that pressure on themselves that they need to be seeing as many patients as they can, and that someone's going to get upset if they don't. And I think perhaps they put a lot of pressure on themselves. And I had this wonderful mentor in the Kimberley, very wise old doctor who's now the head of the Rural Clinical School. And he always used to say, look, Sally, if I see my registrars seeing more than 12 or 13 patients a day in Aboriginal health, I get really concerned and I go and find out what's happening because they're not doing it properly. And I find that really reassuring that, he's a really experienced doctor, and he was just making the point that obviously people need time. And sometimes if the service is very chaotic, I think the system can make the registrar feel like they have to see everyone, and that they might feel that they can't take any breaks. And so I kind of try and flip that back and just put some of the, not responsibility because that doesn't sound fair, but there's some medium and long-term fixes that really need to come at a service level, but the short-term fix, sadly, I think is sometimes to just encourage them to trust their gut feeling and to do what they can do and not feel pressure that they have to fix everything, and put some boundaries for themselves if they can.
That's really great to hear, Sally, and both of you, Sally and Mo, this is an awesome presentation to share with the registrars, particularly prior to the priority practice match coming up, or the mainstream match, just to sort of generate that interest, but understand the challenges and how, the tips for dealing with that. And certainly I'd make the comment, adding on to what you're saying, Sally, is what we're finding, the cultural mentor or the cultural educator that's the person may be nominated on site, it's not always that person, unfortunately. There's a multidisciplinary team that are supporting the registrar, but sometimes that can be an issue too, as in they haven't got that go-to one person for that support. So we're finding that role, if it could be a bit more formalised in the ACTA, would be really, really useful. And then, of course, the supervision is always a challenge too, so bolstering that supervision as well. But yeah, thank you for that. That's great tips, thank you.
I think we're incredibly lucky at FARS as well, that I think the supervisors kind of see it slightly as a pastoral role as well. We're also incredibly lucky that we get amazing registrars, so I feel like perhaps I don't have the most up-to-date answer, but I do think that the supervision is very much a pastoral role as well, because it's such a chaotic environment. And I completely agree with you with the cultural mentor role, that we've tried to formalise it at VARS, and for a number of reasons, it's never quite worked. And in the end, we've discussed it so many times, and the decision was to kind of keep it fluid. But I do talk to registrars and encourage them, and the health workers sort of suggested this themselves, that different registrars will resonate with different people, and maybe allow the registrar to find their person and keep checking in with them, which has worked really well, because some of the male registrars, it's really senior Aboriginal health workers who are incredible, and they formed that really strong relationship. And but that a different registrar might have formed it with a really senior female Aboriginal health worker, and that's worked really well. I think the problem though is when that we all forget, because we're all busy, and that relationship doesn't get formed with anyone, and then there's no formal person. And that's exactly as you say, Karen. I think that's when things can really get challenging, because, and again, I'd love to hear from the Aboriginal people in the audience, but my overwhelming experience with cultural mentorship is that often we as non-Aboriginal doctors are thinking someone's going to sort of say, oh, you should have done this or you should have done that, and there's almost this perception that we'll be fessing up to our mistakes, and that's just so the opposite. All the Aboriginal cultural mentors I've ever approached have been so concerned for my welfare and how I felt about that consult. They've been really surprised that I would be feeling guilty. And really worked hard with me to take that off the table. That's not effective. It's not what it's about. In fact, it's a bit of a burden for the client sometimes to feel that guilt all the time, and to just put that to one side and let's actually just have a conversation about what happened, and everyone's going to be okay. It's okay, So I think when you can get that relationship going, as it can be really, really freeing.
I think that's right. And just reflecting on my time at VARS, because it was as a registrar as well, I think having another registrar that I was there with, so we had that shared experience and we could debrief formally and informally with each other about going, I'm finding this really hard. And thinking back, I think the two of us were the only full-time GPs in the practice at the time. And by the end of the 6 months, we were tired because it is chaotic and it's new. And I was doing my OSCE exams at the time as well. So realising there's these other external pressures on registrars too. And I think because after I left VARS, I went back into a mainstream practice, and I've been in one since. And I've actually been in 4 practices in the last 5 years, because we've moved around a bit, and every time I've always felt a bit guilty about not approaching the local Aboriginal Health Service again, and working within one of those. But I guess it's been the balance of what's been right for my family at the time as well, but also recognising that mainstream general practices need, I hope I am, a culturally safe doctor as well. And so being able to kind of be in a practice and kind of speak to that and go, look, I have experience in this. We could be doing our health checks better. We could, why don't we just stick up a flag? We can print one off the computer. It doesn't have to be fancy or some, massive plaque, but just those little things do make a difference. But I guess, particularly for registrars, going back to that, I do remember feeling overwhelmed, but I think it was partly because I didn't have any balance in my practice at that time. It was 5 days a week in an Aboriginal Health Service that was very well supported, but still quite chaotic and busy and very foreign to what I'd previously done. And I was quite a new GP as well. So I think if there's ways we can kind of build that balance into our registrars programs too. So maybe they have a 12-month part-time thing and mix it with the mainstream break. So then they've got that direct comparison as well. But yeah.
It's such a key point, because I know that a couple of Aboriginal health services in other cities in Australia decided they wanted only full-time GPs 5 days a week, and they found it very hard to sustain a workforce because it is just such an intense environment to work in, and I'm not sure that's great for the doctor or for the service. Look, I'm sure, so no criticism of those services, I'm sure it's working well for them, but I think a lot of people found that they couldn't, even as fully fledged experienced GPs, that was very tough to work 5 days a week is my point. And I think it's
a lot of people aren't doing that in mainstream practice as well.
Exactly.
So perhaps doesn't quite match the expectations of the workforce that, general practice has been desirable because it's flexible. And so if you lose some of that flexibility, it can make some of the harder things harder.
Yes, absolutely. And but having that space in the week for registrars in any AMS to have that time to just reflect and catch up on paperwork and all that stuff, I think is so important.
Thanks so much, guys. Honestly, from just watching the participants, and everyone stayed on, 20 plus people, and have stayed the whole time. Obviously a couple are leaving now, but everyone has just thanked you. Very, very interesting, very informative, and from the bottom of my heart, being an Aboriginal woman, I want to thank you. We need more people like you in, whether it be in AMS or if it's just in your mainstream, because you're absolutely right, Mary, you can bring something to mainstream for sure. You can help. And thank you, because you guys are bloody superstars. So and just so informative and so helpful on your side of things, and you really went through a lot of effort, obviously, and very, very, very grateful. So thank you. Everyone is also very grateful. So thank you.
Thanks very much. We got so much out of it.
Awesome.
Thanks so much, Mary and Sally. We'll definitely share the recording with the registrars and people that weren't able to attend.
Thanks again, guys. You take care.
Bye.
Talk soon. Bye-bye.